Hello, my name is Jacob Priester, and I will be presenting on a project titled The Use of Contrast in Chest CT Staging of Patients with Extremity Sarcoma. Is it overutilized and unnecessary? This was a project that was started during my longitudinal clerkship experience during my third year, where I was working with Dr. Thorpe at his orthopedic oncology clinic. And this was a project where Dr. Thorpe was the PI and was also done with the assistance of Dr. Botany in radiology and my medical student colleague, Justin Choi. And this was done on behalf of the UC Davis Department of Orthopedic Surgery. To start with background, it is well known that the most common site for metastasis for bone and soft tissue sarcoma is the lungs. Therefore, it's common practice to have regular lung metastasis staging studies in these patients. The American College of Radiology recommends staging for lung metastasis via CT without contrast, both at the time of diagnosis and in the 3 to 6 month period following treatment or surgery. But at our institution, there's a tendency to perform CT of the chest with contrast for routine staging, but the exact frequency of this ordering tendency is unknown. Our project was an IRB-approved retrospective chart review of 366 patients diagnosed with soft tissue or extremity sarcoma who received CT screening for metastasis at UC Davis from the years of 2005 to 2020. Patients were reverse searched in the PACS imaging system using sarcoma as a keyword, and they were included if they had a diagnosis of extremity or bone soft tissue sarcoma and documented CT for staging or surveillance. There was no restriction to length of follow-up, and patients were excluded if they had outside imaging or CT of the abdomen or pelvis. We also specifically excluded patients with the diagnosis of myxoliposarcoma, atypical lipomatous tumor, or well-differentiated liposarcoma. Ultimately, 128 of our original 366 patients met our inclusion-exclusion criteria. Essentially, we compared how often patients were receiving CT with versus without contrast year by year, as well as the ordering tendencies between various specialty providers at UC Davis. We also compared the ability for contrasted studies to distinguish sub-centimeter nodules or less than 5 millimeter nodules into either indeterminate, benign, or metastatic lesions. And finally, an institutional and patient cost analysis was performed between CT modalities over the years. Our data was displayed with basic descriptive statistical analysis without high-power statistical analysis, as that was just deemed unnecessary for our study. Our data collection yielded many different results showing an overarching theme that the majority of providers across all specialties at UC Davis are ordering and executing CT with contrast for staging as opposed to without contrast per the ACR guidelines. So figure 1 shows the total number of CTs ordered year per year, year by year, CT with versus without contrast for all patients in our population. And you can see that even after 2015, when the guidelines were published, there hasn't been a significant improvement of the ordering tendency of CT with contrast versus without. Figure 2 shows a little bit more striking example of this trend in that it shows the final CT ordered for all 128 patients. And even after 2015, 81 of the 92 patients that had their final CTs were ordered with contrast as opposed to without contrast. As you can see in figure 3, only 32 patients in the entire population had sub-centimeter or less than 5 millimeter nodules, and 28 of those patients were labeled as indeterminate, regardless of whether or not they got a CT with or without contrast. And only 4 patients in the entire population, or 12.5% of the original 32, were diagnosed with metastasis, but all of those patients underwent CT with contrast as opposed to without contrast. And then finally, figure 4 shows a basic cost analysis of the difference between the imaging modalities. So we were able to show that the difference in modality cost was $199. So the average cost incurred per patient was around $1,300, and the total institutional cost was around $167,000. Overall, our study shows that UC Davis as an institution has been non-adherent to the ACR guidelines for sarcoma metastasis screening in regards to using CT without contrast versus CT with contrast. And in fact, the overwhelming majority of initial and final CTs after 2015 were ordered and executed with contrast. So with this data, there's an opportunity to educate our ordering providers from all specialties on the ACR guidelines, and hopefully improving ordering patterns will reduce both patient and institutional costs. Although this is a small sample size, our initial data suggests that CT with contrast does not offer a significant clinical advantage in diagnosing sub-centimeter or less than 5 millimeter nodules, seeing as most of the patients were diagnosed as indeterminate nodules as opposed to metastatic or benign, regardless of whether or not they had CT with or without contrast. And in terms of future directions, despite the American College of Radiology's recommendation that CT without contrast be the study of choice for metastasis screening, there's actually a paucity of data showing that CT without contrast is actually as efficacious or non-inferior to CT with contrast for screening. So ordering in concordance with the ACR guidelines at our institution could contribute to a non-inferiority study in the future. This concludes my presentation. Thank you.